Bueno, vamos a comenzar esta quinta reunión de educación médica continua de la Sociedad Chilena de Trastornos Bipolares. Esta noche contamos con la presencia virtual del doctor Nassir Ghaemi, quien es profesor de Psiquiatría y Psicofarmacología de la Universidad de Tufts en Boston. No, mi nombre es Jorge Cabrera, yo soy el presidente de la Sociedad Chilena de Trastornos Bipolares y les damos la bienvenida a todos quienes están hoy día en esta cuarta sesión del ciclo de educación médica continua, que hoy día vamos a tener al doctor Nassir Ghaemi, como ya dijimos. Nuestra próxima reunión será el día 12 de agosto a las 8 p.m. En esa oportunidad, el doctor Tomás Hayek de la Universidad de Dalhousie en Nueva Escocia, en Canadá, va a hablar sobre la relación que hay entre diabetes mellitus y la salud del cerebro en los pacientes bipolares. Queremos también informarles que, como ustedes saben, Subtype está realizando este año el ciclo de psicoeducación vía online. Y esta serie de charlas han sido bastante concurridas. La semana pasada, el sábado recién pasado, tuvimos alrededor de 180 personas. Y nuestra próxima sesión va a ser el día sábado 8 de agosto a las 11 a.m. Y en esa oportunidad la psicóloga, la señora Mariela Said, va a hablar sobre detección precoz de recaída. Nuestra tarea es convocar cada vez más pacientes y familiares. Les invitamos a todos ustedes, a todos los médicos, psiquiatras y psicólogos que hoy día están acá en esta sesión, que compartan el link para que los pacientes asistan a estas sesiones. El objetivo de Subtype y del Círculo Polar es finalmente formar monitores o especialistas en apoyo a pares. Nos parece que esta es una tarea de una tremenda importancia en todo Chile. Nosotros estamos planificando para, a fines de este año, crear filiales de esta sociedad en las regiones y queremos que el Círculo Polar se extienda a las ciudades más importantes de Chile. Tenemos planificada desde ya una reunión para el mes de octubre en Valparaíso y Viña del Mar, y queremos también extendernos a Concepción. De tal manera que, repito, inviten a vuestros pacientes y familiares de pacientes a hacerse parte del Círculo Polar y asistir a este ciclo de reuniones de psicoeducación sobre el trastorno bipolar. El último aviso que quiero dejarles esta noche es la invitación a nuestras octavas jornadas Subtype, que este año serán de manera virtual los días 9 y 10 de septiembre en las mañanas. Tenemos invitados internacionales de primera línea. Estará la doctora Trisha Supes, quien es la past president de nuestra sociedad madre, la ISBD. Tenemos al doctor Bradley Peterson, también un psiquiatra de niños y adolescentes, y a la psicóloga María Reinares, quien trabaja en el Hospital Clínic de Barcelona y tiene una vasta experiencia en psicoeducación y en remediación funcional de pacientes bipolares. De tal manera que las inscripciones las pueden hacer desde ya, tienen que hacerlas en nuestra página www.subtype.cl. Bueno, quiero pasar entonces a presentar a nuestro invitado de esta noche, el profesor Nassir Ghaemi. El doctor Ghaemi tiene un antiguo vínculo con nuestro país y han sido muchos los colegas que se han formado con él allá y que de verdad ha dejado en Chile un legado muy importante. Él es profesor de psiquiatría de la Escuela de Medicina de la Universidad de Tufts en Boston. Es director del programa de trastorno del ánimo del Centro Médico de TAPS y sus áreas de investigación son la depresión, el trastorno bipolar y también la literatura. Él es PhD en Filosofía y Salud Pública, es fundador y editor de la revista Psychiatry Letter, que es una revista mensual de psiquiatría para clínicos, y es autor de más de 250 artículos revisados por pares. Ha escrito más de 10 libros, y dentro de los libros en realidad más importantes que él ha escrito está uno que para mí tiene un valor especial. Este libro, Bipolar Depression, creo que ha abierto a los clínicos la posibilidad de hacer el diagnóstico del trastorno bipolar de manera precoz, focalizando en el cuadro clínico fenomenológico de la depresión. Todos estos otros libros son también, desde luego, muy valiosos. Un libro que hoy día está en primer plano es este que se llama First Rate Madness, una relación entre liderazgo y enfermedad mental, por una serie de razones respecto de los líderes que nos conducen hoy día en el mundo, de tal modo que este es un libro que yo recomiendo en particular que ustedes lo lean. Con esto dejo a Nassir, voy a dejar de compartir mis diapositivas y Nassir puede pasar a compartir las tuyas.
Okay, good. Gracias, Jorge. Gracias, Paul. Gracias a todos mis compañeros y amigos en Chile que me han invitado. Thank you all for inviting me for this presentation. I'm going to give it in English and it will be translated for you. Let me see if I can share my slides. If you can confirm you can see my slides.
Yeah.
Okay, good.
You have to put them presentation.
There you go.
Okay. There you go.
Perfect. Okay. All right. Well, thank you. Thank you for the invitation again. Gracias a ustedes, amigos cercanos míos en Chile. I have very, very strong attachments, of course, to my friends in Chile. Paul Voringer, Sergio Barriole, who have both trained with me here in Boston, and the folks in the University of Chile, who sent them and who I've gotten to know, especially Luis Risco, the chairman, who's a good friend. So thank you all for inviting me again. We had hoped to do it in person, but a virus and a lot of very bad leaders in the world have prevented us from doing it in person. We can have another talk about that maybe another time. The topic that we decided to have today is the topic of DSM and what use it is in mood disorders. And as you might see from the title in English, I think it has failed, and I'm going to try to explain why it is not useful. My first disclosure here is that in addition to my academic university work at Tufts and at Harvard, I am also in the last 3 years involved with early drug discovery at Novartis in Cambridge, Massachusetts. But the views I'm expressing here are just my own, do not reflect at all those of Novartis or anyone else. So the background sources for this discussion, if you would like to review this material yourself later, are these books. The book by Decker is the most comprehensive history of DSM-3. The book by Edward Shorter is also a history of DSM-3 specific to mood disorders, the topic of today. So that's the book I would recommend the most to you. If you go online besides my book, to psychiatryletter.com, you can also see some essays I've written on this topic, which will provide links to other articles. So the first point I want to make as we get into this topic is that our best drugs are our oldest drugs. If you look at each drug class, basically the medication in that class that's most effective was developed in the 1960s or earlier, as you can see here. And I want to highlight here another feature of these drugs, and a very important feature that's underappreciated in psychopharmacology. And that is that you really can divide drugs into two groups: symptomatic drugs and disease-modifying drugs. Symptomatic drugs are drugs that improve the symptoms when someone has it, but they don't affect the underlying disease in any major way. Standard examples in medicine are Tylenol for a fever or aspirin for a headache. The Tylenol for a fever improves the symptom, but it does not affect the infection that's causing the fever. The antibiotic would be the disease-modifying drug, which doesn't improve the symptom of fever, but improves the cause, which is the infection. If you look at this list of drugs, almost all of them are symptomatic drugs. Almost all psychiatric drugs are symptomatic drugs. They are not disease-modifying. Antipsychotics improve delusions and hallucinations, but they don't improve the course of schizophrenia. And then they don't improve the pathophysiology of schizophrenia. In fact, they make cortical atrophy, which is part of schizophrenia, worse. Antidepressants, as we'll review, are very mildly symptomatically beneficial for depression symptoms, but they don't improve the course of depression, and they don't improve its underlying pathophysiology. They don't prevent suicide. They don't decrease mortality. Benzodiazepines are Tylenol for a fever. They improve anxiety symptoms, but they don't get at the cause of the anxiety. Amphetamines improve concentration, but they don't get at the cause of the problems that people have that cause poor concentration. The only exception in this list is lithium. Lithium and perhaps a few of the other mood stabilizers are the only disease-modifying drugs in psychiatry, in my view. They don't actually improve symptoms directly much, although they do to some extent. But their main benefit is in the long term. Lithium prevents mood episodes. It improves the course of the illness of unipolar depression and bipolar illness. Not only that, it does prevent suicide markedly, unlike antidepressants. And not only that, it actually counteracts the cortical atrophy, which is part of the natural history of mood illness. Unlike antipsychotics, it does not worsen cortical atrophy, it improves it. It leads to cortical regrowth and improvement of the neurological state of the brain. This is one reason why some of us have been thinking that lithium may be an effective treatment to prevent dementia, for which patients with mood illnesses are at high risk. And I do want to mention that I appreciate that Europharma in Brazil has been assisting my colleague, Dr. Paul Voringer in Chile, to prepare a study of lithium in dementia as a randomized trial, which the world desperately needs. This could be a very simple solution to the international problem of Alzheimer's dementia and other dementias. A very simple and cheap solution, but one that is not being developed by the pharmaceutical industry because of the generic nature of lithium. So lithium is a disease-modifying medication, not only for mood illnesses, but potentially also for dementias. And the rest of these medications are only symptomatic drugs. So we often talk about how great our drugs are and how excellent psychopharmacology is, but essentially we have 50 variations on Tylenol and aspirin. And that's not actually, it's not useless, it's helpful for symptoms, but it's not actually a profound benefit to patients with psychiatric diseases. We have very few drugs that affect diseases. Now that said, even with this symptomatic benefit that we have, the drugs that have the most symptomatic benefit are drugs that were developed in the 1960s or earlier. And the question is why? The newer drugs, by the way, like the famous serotonin reuptake inhibitors that everybody loves so much, are not more effective than the older drugs. They are only more tolerable. And you could say the same for most of the new antipsychotics and anticonvulsants that have come out. They are not more effective than the older drugs. They just have less side effects. That's not a minor thing because many more people can take these drugs. But we have to realize that the price of having drugs which are easier to take because they have less side effects, but are less effective, is that many more people take them, but they get less benefit. So what changed? Why have we had less effective drugs since the 1960s or 70s? Before then, before the 1960s and 70s, there was no government regulation of drug development for efficacy. The only regulation was for safety. But in 1962, the US government passed the law so that the Food and Drug Administration required proof of efficacy before medications were allowed on the market. And that change partly happened because the concept of randomization was developed and widespread in the 1950s. And so now there was a method, a tool to prove efficacy, which was randomized trials compared to placebo. Before the 1950s, there was no way to really prove efficacy, and that's really why it wasn't regulated. Another change was that before the 1960s and 70s, mainstream American psychiatry was psychoanalytic. It therefore ignored drugs. It didn't really care about medications. It also didn't care about diagnosis, because you didn't need a diagnosis for psychoanalysis. Psychoanalysis basically conceptualized phenomena in psychopathology as a continuum from neurosis to psychosis, and all of those patients were to receive psychoanalytic therapy. The only difference was you received more or less, depending on where you were on the spectrum. And another change is that before the 1960s and 70s, when these early first generation of medications were created in the 1950s and 60s, almost all of those drugs were developed in Central Europe by pharmaceutical companies in Central Europe, not in the United States. Most of these companies were in Germany, Switzerland, or France. From the 1970s to now, the big changes are the opposite. We have heavy regulation of drug development by the government, by the Food and Drug Administration. Mainstream psychiatry has become biological more so, and practice has involved much more use of drugs. And of course, the big change in diagnosis with the rise of DSM-3 and the importance given to DSM diagnoses for drug treatment. And that's what we're going to focus on today. And also, it should be noted that a shift happened from European drug companies to American drug companies in terms of drug development, which also is important, perhaps in more complex ways than we can discuss today. So, a comment about what mainstream American psychiatry was like when the change for DSM-3 happened in 1980. Before the 1970s, American psychiatry, as we mentioned, was mostly psychoanalytic, and drugs were viewed as unimportant, superficial, and symptomatic. Again, like aspirin for a headache, Tylenol for a fever. After the 1970s, when drugs became more prominent, the field became more biological, partly because there were so many drugs that were available. And the biopsychosocial model concept was developed as a compromise so that psychoanalytic concepts could also have a place in the field. And a major increase in attention to diagnosis was given, as we'll discuss, with DSM-3 being introduced in 1980 and having a huge impact on the field. And furthermore, from the 1970s onwards, drugs were viewed as more than just symptomatic. The assumption was that they were some kind of deeper and more profound treatment. For instance, when you gave a tricyclic antidepressant for a severe depression, the whole depressive episode went away after a month or so. When you gave an antipsychotic for a manic episode, the whole manic episode went away. When you gave antipsychotics to patients with schizophrenia, so many of them got so much better that many of them were able to leave the state hospitals in which they had been forced to live for years and decades even. So these were all massive improvements. And it gave clinicians the impression that these were not just symptomatic treatments, that they were doing something more profound. I think after 50 years, we can say, for the reasons I gave earlier, that since these drugs don't change the course of the illness, don't improve the pathophysiology of the disease to the extent we understand them, generally speaking, don't prevent suicide and don't reduce mortality. For all these reasons, I think we have to admit that the drugs do not have disease-modifying effects, and therefore the psychoanalysts were right from the 1970s. These drugs are only symptomatic, most of them, and they are not more profound. Now, it's true, the symptomatic benefit can be very important. So a full manic episode does go away with antipsychotics. Patients with schizophrenia do have major improvements in the severity of their symptoms, but it is still a symptomatic effect. It's not a disease-modifying effect. And that leads us then to this dilemma in terms of how we should practice medicine and psychopharmacology. The tradition that some of us have been taught that goes back to Hippocrates is based on this picture, namely that the Hippocratic tradition held that drugs should not be given for symptoms, they should be given for diseases. So when the patient presents to the physician with symptoms, the job of the physician is not simply to give a drug for that symptom. It's to find out if there's an underlying disease that's causing that symptom. So if you have a pneumonia, you'd be a bad physician if you just gave a patient a drug for a fever and a drug for chills and a drug for night sweats, instead of a drug for the underlying disease of pneumonia. And the job of the physician first is to identify what that disease is. Sometimes patients don't have diseases. Sometimes patients have headaches and fevers and there's no disease, there's no cause. When that's the case, the physician is not supposed to give aggressive, unlimited, long-term drug treatment for symptoms. Generally speaking, that's not recommended. You might give very brief short-term symptom treatment, but overall, in the long run, you're not supposed to treat those patients with drugs. Similarly, if the patient is going to a surgeon, the surgeon has to figure out what kind of disease the patient has. If the patient has a disease that the surgeon can treat with surgery, he can recommend surgery. But if the patient doesn't have a disease or does not have a disease that's treated with surgery, he should not do surgery. Same thing with the drugs. I find that surgeons understand these concepts better than non-surgeons do, because it's a very bad surgeon who operates on everybody he sees. In fact, I'm sure that most surgeons statistically in their practices do not operate on the majority of people that they see. They only operate on a minority. But psychiatrists and many physicians in other specialties give medications to the majority of the patients that they see. And that's a non-Hippocratic approach, because the way the psychiatrists are practicing is to give medications for symptoms. And they're not really working to identify what the underlying disease is. And furthermore, they're not making the judgment, even if the patient has a disease, whether it's treatable or not. Many diseases are not treatable. Or sometimes the diseases are self-limiting. The symptoms go away by themselves. And in that case, there is no need for treatment. The only patients that should be treated are the ones that have diseases that are treatable. And this is the basic philosophy behind the Hippocratic concept that's misinterpreted as first do no harm. By the way, Hippocrates never said first do no harm. He said, as to diseases, try to help or at least not harm. So the more important thing, the way you end up not harming patients is by not treating symptoms, by treating diseases. So this brings us to the question in psychiatry, what are the diseases? If we're not supposed to treat symptoms, what are the diseases that we're supposed to treat? And that's essentially what the diagnostic system is supposed to help us identify. The DSM-3 system, which has now been continued for 40 years, claims to be a diagnostic system for disorders, trastornos. But the term disorder is vague on purpose. And what we really need to know is what diseases we're treating. Now, if you go back in the history of psychiatry, the most successful experience in psychiatry for the treatment of a disease is syphilis or neurosyphilis. In the case of syphilis, patients had psychosis and they had manic and depressive episodes. And the treatments for hundreds of years was, as you can see here, bleeding, which was a standard treatment in medicine, and mercury. But mercury caused lots of side effects, as you can see, including gum ulceration, tooth loss, and psychosis itself. Now, neurosyphilis was carefully described in the 1800s and 1900s, so that by the time that in the early 1900s, when antibiotics were starting to be developed, patients with neurosyphilis could be tested. And these patients were given the label general paralysis of the insane. That was the diagnostic term, because they didn't know it was syphilis at the time. But over time, they found that patients with general paralysis of the insane had positive tests for syphilis when syphilis was identified. whereas patients with schizophrenia and manic depressive illness did not have positive tests, even though the syphilis patients had symptoms that were very similar to the schizophrenia symptom patients and the manic depressive patients. In fact, syphilis was as common of a diagnosis back then as schizophrenia is now. It was about 1% of the general population for neurosyphilis with psychosis. So once the patients were separated, the neurosyphilis patients from the schizophrenia and manic depressive patients, they were able to be treated differently, and you could see that antibiotics, initially arsphenamine, and later penicillin, and then in the meantime also malaria fever therapy, for which a Nobel Prize was given, were all effective in the neurosyphilis patients, but they were not effective in the schizophrenia or manic depressive patients. By the 1940s, when antibiotics came along, neurosyphilis was cured. And that 1% of the general population who had psychosis was cured. So imagine if today a drug came along that cured everybody with schizophrenia so that they never had psychosis again. And nobody else ever developed schizophrenia again because they would get the drug immediately and they wouldn't go on to develop schizophrenia. That's what happened with penicillin and neurosyphilis. That's why you could say that penicillin is the most effective psychotropic drug ever invented. But if you think about the fact that penicillin, which is an antibiotic, is the most effective psychotropic drug ever invented, you have to appreciate then that the reason that it was so effective was because the diagnosis of neurosyphilis reflected an underlying disease of syphilis, which was treatable then with an antibiotic. Does the diagnosis of schizophrenia reflect an underlying disease that can be treated with anything? It's possible, but that's the question. And I think that's the big issue with the DSM system, as I'll explain further in this presentation, that the diagnoses do not reflect underlying diseases. And the reason we don't have very effective treatments is because studies of the drugs for the DSM diagnoses, which do not reflect diseases, can never be effective with any treatment because there's no disease to treat. Let's back up and give you a little sense of how we got here. In the history of the development of DSM-3, there are three factors that led to the specific diagnoses that we have. One was scientific research, which was based on validators of diagnosis that we'll review, like genetics and course of illness. The second factor was practice. Doctors had started to use antipsychotics, antidepressants, and lithium. And therefore, it seemed that the drugs were similar to the diagnoses of depression, bipolar, and schizophrenia that had been used by some at that time. Furthermore, psychotherapies were used for psychoanalytic concepts like narcissism, and around then the concept of borderline personality was developed and such. And so it seemed that the practice of psychotherapy supported using diagnoses like borderline personality and narcissistic personality. So some of those diagnoses were put in DSM-3 simply to reflect practice, not necessarily based on science, but just based on practice, beliefs, and habits. The third factor is a political, economic, and social factor, which is that the rise of the use of drugs and the rise of pharmaceutical companies threatened the economic power of psychotherapists, who were mostly psychoanalysts. And therefore, the biopsychosocial model was developed as a compromise so that both groups, the psychopharmacologists and the psychoanalysts, could continue to practice and justify the use of both drugs and psychotherapy. DSM-3 also was a compromise because it provided diagnoses for the use of drugs, so-called Axis 1, and then it also provided diagnoses for the use of psychotherapy, so-called Axis 2, or personality disorders. And those diagnoses provide justification for the economic power of both the drug-treating psychiatrists and the psychotherapy-treating mental health professionals to continue. Now, to focus on the science part, the four validators of diagnosis are described here: symptoms, genetics, course of illness, and biological markers if present often the treatment effects are used. DSM criteria are completely based on symptoms, but to the extent that the DSM criteria are scientifically validated, they do not rely and cannot rely just on symptoms, but they rely on these other factors, genetics and course of illness and biology. The reason for this is, as you well know, symptoms are nonspecific. In medicine, you can have a cough and a fever, and that doesn't mean you have the same disease every time you have a cough and a fever. Many different diseases can cause cough and fever. So symptoms are not diagnostic by themselves. You have to have other sources of evidence. In the case of general medicine, you might have laboratory tests and pathological specimens, which are of course best. In the case of psychiatry, in the absence of those validators, you may have genetics. In the case of a highly genetic condition like bipolar illness or schizophrenia, you might have course of illness, which really is what Kreplin emphasized most, the age of onset, whether the disease is episodic versus chronic, and whether it improves or not. And sometimes treatment effects can be useful. So these are the different validators of diagnosis that were used. In the case of mood disorders, as we'll discuss more later, it was claimed that manic depressive illness could be broken down into unipolar depression and bipolar illness because of different genetics and course of illness. And in retrospect, I think 50 years later, we can say that the research has not supported that decision, which we'll discuss more in a minute. Now, using this concept of diagnostic validators, a group of researchers in the 1960s and 70s, which was very prominent, developed the concept of 10 major categories of diagnoses, as you can see here. This was described well in this classic textbook, which is still in print in its later editions. And the reason I'm showing you this is, as we'll see, with DSM-3 and later, you have 300 and more diagnoses. But in reality, the scientific research using the validators of diagnosis really can be said to support only maybe about 10 different diagnostic groupings. This was elaborated further to about 22 diagnoses in the research diagnostic criteria, so that those big groupings are further broken down for you here, as you can see. In the research diagnostic criteria developed in 1978, had these different groups. Here's more of them. They add up to 22 diagnoses. So we went from 10 diagnoses to 22 using scientific criteria alone. You'll notice that not being mentally ill was also a diagnostic group, which is an important one. 1978 is when the research diagnostic criteria were fully published, although some variants of them were present earlier. 2 years later, 1980, is when DSM-3 was published. And the DSM-3 task force was at work for a number of years before that. So in those couple years, in the late 1970s, when you move from the research diagnostic criteria to DSM-3, you go from 22 diagnoses to over 300 diagnoses. Now, how did that happen? This is where we go to the evidence that's not just scientific, but that's economic, political, and practice related. Now, there's a couple ways that this has played out. One is that with DSM-3, because of the psychoanalytic powers in psychiatry did not want diagnoses to be identified as diseases, they rejected the use of the phrase disease. Keep in mind that psychiatry at that time was mainly in the power of psychoanalytic groups. So they didn't want to use the word disease. In DSM-2, which was written in 1968, they had used the word reaction, which was more of a psychoanalytic concept. But the groups that supported the use of drugs and biology did not want to use the word reaction or neurosis either, which was seen as too psychoanalytic. So they compromised on the term disorder, because the word disorder has no meaning. It can mean disease, but it can mean a psychological problem or a reaction as well. And therefore, it's sufficiently vague that everybody could claim it to be whatever they want it to be. And to the extent that it is defined, the term disorder in the DSM system is defined as having severe symptoms plus functional impairment. In almost all cases of diagnosis in DSM, to get the full diagnosis, you need to have notable, marked occupational and social impairment, and usually with severe symptoms. Now notice that this is an interesting criterion for requiring it to be met to make a diagnosis in psychiatry. Nowhere in the rest of medicine is this a criterion. You would be a very bad physician, certainly unscientific, if you said that you would never diagnose cancer unless someone has severe symptoms and functional impairment. You would never diagnose coronary artery disease unless you have severe symptoms and functional impairment. You would never diagnose hypertension, high cholesterol. You would never diagnose epilepsy. You would never diagnose anything unless you had severe symptoms and functional impairment. Well, if you do that, obviously a lot of people are going to develop cancer and die from it. A lot of people are going to have heart attacks and die from that because you're refusing to diagnose those conditions when the symptoms are mild or when there are no symptoms at all. That's very unscientific and anti-medical. A lot of times people say the DSM-3 is the medical model, DSM-4 and 5. A lot of colleagues in the social work profession, a lot of psychologists like to say that psychiatrists are using the medical model when they use DSM. DSM is not the medical model at all. This is the anti-medical model to require severe symptoms plus functional impairment. DSM is not medical and it's not scientific at all. Now, the approach that could have been used and was used in the German tradition in the early 20th century involves saying that there are diseases and we should call them diseases. Now, sometimes you may not know if they're diseases, that hang together, where patients with a certain kind of symptoms, genetics, course of illness, maybe biology, they're different than patients with another presentation. So post-traumatic stress, for instance, could be seen as a clinical picture. It may not be a disease, but it is a clinical picture you see. Borderline personality, perhaps. Other conditions are clinical pictures for which there is sufficient biological evidence that there's an underlying disease process. It could be genetic, it could be environmental, but it involves underlying biology. And this is what the Germans called Krankheitsprozesse and disease processes. And I think that these two concepts, to me, are much more meaningful than the term disorder. If we take this approach, we use disease concepts where appropriate, but we also do not use disease concepts where we do not know if they're appropriate or where they may not be. And the concept of clinical picture is more useful. Another aspect of DSM-3, which I think has been quite harmful, is that they remove the concept of a hierarchy of diagnosis for almost all diagnoses. As you can see here, one approach that one could take to psychiatric diagnosis is to realize that some conditions are polysymptomatic and they cause so many symptoms that those symptoms are present in other conditions. For instance, mood illnesses, as you know, can cause psychosis, just like schizophrenia. They can cause anxiety, just like anxiety conditions. They cause changes in your personality, and they cause concentration impairment and cognitive impairment, which can be diagnosed as ADHD. So instead of diagnosing patients with mood illnesses with these other conditions, we should not diagnose the conditions below until we rule out that the person has a mood illness. And if they do have a mood illness, we should treat it and see if any of these other symptoms persist. Because a lot of times when the depression or mania is treated, the psychosis, the anxiety, and the concentration all improve. This is the case when we distinguish between schizophrenia and mood illness. That's the one scenario where a hierarchy is in DSM-3, and you're not supposed to diagnose schizophrenia if someone's delusional, unless they don't have mania and depression. And that's an example of how it works. But for some reason, for the rest of DSM, the writers and authors of DSM have refused to take this approach. And in fact, they explicitly take the opposite approach. They encourage and they enforce that people make as many diagnoses as possible, which they falsely call comorbidities. These are not comorbidities. These are just mistaken diagnoses when you have overlapping symptoms and you call every symptom a diagnosis. Nature is not so terrible that every time it gives someone a disease, it gives them 3 or 4 at once. Every time someone has mood illness of depressive conditions, they don't automatically also get an anxiety disease, an ADHD disease, and a personality disorder at the same time. But that's the way we practice and diagnose. In medicine, as you know, you're taught to make a differential diagnosis. So when a patient presents to you with symptoms, you're supposed to have a hierarchy like this and rule out diagnoses one by one until you can find the one diagnosis that the patient has that explains most of the symptoms. In psychiatry, we don't do that. We refuse that standard medical approach. Another example of how DSM is anti-medical and non-medical. Now, after DSM-3 in 1980, there were very few changes made in DSM-4 and DSM-5, and DSM-5 being the most recent in 2013. And they have a very basic philosophy that hasn't changed. The leader of DSM-4, in some of his debates with me, has been very explicit, and I think he describes it well, that this philosophy is pragmatism. Pragmatism means not what does the science show, it means what do the DSM committees think is the best decision. And the DSM committees are comprised of prominent psychiatrists and sometimes researchers, but not always researchers. They're often administrative leaders like chairman of department and such, many of whom hardly ever do any research at all. I know most of the members of the DSM committees for DSM-5. Many of them are good friends of mine, colleagues. This is not a personal criticism, but they're not researchers often, or at the very least, research is not their primary criterion. The leaders of DSM-4 and 5 were clear that the primary criterion for making a change in DSM criteria is what outcome it would have, what change it would have in practice. And this practice change they see as being for the benefit of society and of the profession. But that's a judgment that's being made by psychiatrists, by academic leaders in the American Psychiatric Association. It's not a judgment that's based on scientific research. It's an opinion. Now, why do they do this? Why do they not just say, let's put the scientific research as the sole criterion, irrespective of what we think is best for society or for the profession? In my view, and this is, I think, the core of the problem, is that the DSM philosophy is postmodernist. What that means is that they do not view science as being more true than anything else. They view science as being, as the postmodernists call it, a form of discourse of power. So for instance, the pharmaceutical companies have power, so they influence the scientific research. Or the leaders of the profession have power. They're the ones who give out the grants. They're the ones who edit the journals and decide what gets published. So they influence what appears to be the scientific evidence. And because of these social and economic factors, we can't believe the science. It's no different than non-science. And there is no real truth here. And that's why I think deep down, many of the leaders of psychiatry for the past 40 years have viewed diagnoses as arbitrary and therefore don't have any guilt or any problem with creating and changing diagnoses however they like with DSM criteria based on what they believe is the best for society. The leader of DSM-4 even said in one of his debates with me, when I pointed out this problem, and I said that the experts in research are the ones that one should be relying on for decision-making on diagnostic criteria, he said, don't believe the experts. The experts are the last people you should believe. And I think that's a good classic postmodernist idea. It's also not a coincidence that these changes happened in the 1970s, because the postmodernist ideology of the modern world began with the counterculture of the 1960s and 1970s. And most of the leaders of DSM-3 were in their 20s and 30s back then, and they were young men, mostly men, who were heavily influenced by that counterculture postmodernist ideology, even though they were unaware, and they are still unaware, that they actually are postmodernist in their ideology. They haven't studied philosophy. They haven't carefully studied these concepts. They unconsciously accepted them, and they practice this way of thinking without realizing why or what it is. This postmodernist ideology has become mainstream in the world from the 1980s and the 1990s to now, all through our society. And it's clearly obvious in the case of science and medicine, and you can see it these days. It's, in my view, a big part of why the coronavirus pandemic isn't being controlled, because people don't believe in the science. They don't respect the science. It also relates to vaccines and people not taking vaccines. It relates to climate change and rejection of the science there. But psychiatry has been a classic target of the postmodernist critiques, where they say that psychiatrists are just like policemen of society. They make up diagnoses to treat and control the mentally ill, who are merely different people who reject societal norms. As you know, the anti-psychiatry movement since the 1960s and 70s has made this view. Drugs in particular are seen as very harmful. And then when they see that there's a pharmaceutical industry that makes profits from those drugs, it's an easy target as well. And of course, the profession itself, the physicians, the psychiatrists who make money from practice, whether it's with psychotherapies or with drugs, they have an economic interest in diagnoses that they can make incomes from. So these are the postmodernist critiques that have been leveled at psychiatry since the 1960s and 70s. And it's interesting that even though the critics of psychiatry take these views, the mainstream of psychiatry itself, in my view, has the same views, because the leaders of DSM have set it up that these diagnoses are arbitrary, changeable based on opinion, and not primarily based on science, which is exactly the same attitude that their postmodernist critics have. So DSM leaders are fine with essentially making up diagnoses. I'll explain, give some examples in the case of mood research. And the problem here is that if you make up diagnoses based on the professional, cultural preferences of the American Psychiatric Association in 1980 or 1994 or 2013, you do not make diagnoses then based on the nature of the genetics or the biology of reality. And when you do genetics and biological research and neuroimaging research, you find that those diagnostic definitions don't work. And that's why for 40 years, that research has been mostly failures. And that's also why in 2013 with DSM-5, the NIMH finally admitted this problem and stated that they would no longer use DSM criteria for research. Well, if DSM criteria are scientifically false for research, as proven based on 40 years of history and now accepted by the NIMH, if they're scientifically false for research, why are they scientifically acceptable for practice? And the APA has refused to accept this dilemma, and they say that people should still practice with criteria that are no longer acceptable for scientific research. And this problem has sometimes been called the reliability validity problem. Let me just point this out, because people often will say, well, DSM was reliable. The point of DSM was to have the same definitions. And by using the same definitions, like a dictionary, we at least could speak the same language. That's fine. But as you know, DSM-3 onwards has been called not only a dictionary, but also the Bible of psychiatry. And what's happened instead is we created a dictionary which we've begun to worship. And once you worship the dictionary, you're not going to make it more valid by research. And that's what's happened. We don't want to change the diagnostic criteria because we worship them. The major depressive disorder, so-called MDD criteria, for instance, have hardly changed at all from 1980 to now. Very, very minor changes. And in fact, the leaders of the MDD task force in DSM 3, 4, and 5 have mostly been the same people. And despite that, and the claim that we have reliability, the kappa value for reliability in DSM-5 was actually worse than in DSM-3 in 1980. So 40 years of using the same criteria have not actually led to improved reliability. But that being said, even if you did have good reliability, what has happened is that this reliability has not translated into validity. In other words, the claim was that we would diagnose these conditions the same way, then we would do research and change the criteria based on research to make them gradually more and more valid. But in fact, what's happened is we've diagnosed criteria and we've refused to change them because we started worshiping them. And then we have all these pragmatic reasons not to change them. I'll give you examples. And then you don't get more valid data. And that leads to the ultimate decision correctly that we shouldn't use DSM diagnoses at all for research because they're not valid. DSM, therefore, has become more conservative. The first diagnostic definitions given in 1980 were based on limited scientific research. But to make changes in 1994 with DSM-4, DSM-5, the leaders of DSM have explicitly told the members of the committees that they should not make changes in the DSM criteria unless they have very, very strong scientific reasons and research to do so. And even then, they don't accept some of the changes. So in 1980, you could make 1 million changes based on very little research, but in 1994 and 2013, you could hardly make any changes, even with a whole lot more research. A good example of that is the definition and the classic, the core issue here, that manic depressive illness was divided into two groups, bipolar disorder and so-called major depressive disorder. We'll call it MDD. It was originally called bipolar and unipolar, by the way, but the term unipolar was dropped because the psychoanalysts opposed the term because they thought it was too biological. So then the term unipolar was changed to major depressive disorder, and then the term minor depressive disorder was used as an alternative for neurotic depression because the more biologically oriented psychiatrists thought the term neurotic was too psychoanalytic. But then the psychoanalysts got unhappy with the term minor depression because that was a phrase that they needed to use for insurance, and they thought they would get less insurance billing from the phrase minor depression than major, so they dropped the term minor and they incorporated it into the major group. So somehow we got the term bipolar, even though we dropped unipolar, and we got the term major depression, even though we dropped minor depression. And now we're left with this bipolar MDD combination, both of which are false concepts in a way, because their contrasts have been dropped. But the big point is, let's back up, that the concept of manic depressive illness was very broad, and it was divided into the bipolar and unipolar distinction. This was based partly on research by Jules Angst in Zurich, 60s. Found that if you a population, they had different genetics and different course of illness if they had manic episodes, bipolars, as opposed to not having manic episodes, unipolars. The term manic depressive illness before then included both bipolar and unipolar subgroups. It didn't matter if you had depression or mania, you could have either one. But because the genetics and the course was different, the claim was, okay, well, we should divide into these two groups. And they did. This is a radical change because for 100 years, the two groups were seen as two variants of the same illness, manic depressive illness, not as two different diagnoses, two different illnesses. Now, after 1980, for the last 40 years, Jules Angst's Zurich cohort study has continued. In fact, that study started in 1960. Jules Angst is now in his mid-90s. Most of the patients, he had thousands of patients in his study that he followed throughout their lives, starting around age 20. He followed most of them until they died. He had 40 more years of research. And in the research that he published in the last 30, 40 years, he found that actually the genetics and the course of the illness for the unipolar and bipolar groups overlapped a lot. They were not different. And therefore, as a good scientist, he said he was wrong. And this distinction shouldn't be made the way it was made between bipolar and unipolar being completely different. And there's a lot of overlap, and he's been arguing for a bipolar spectrum concept, or at least a mood spectrum concept. In other words, he's going back to the old manic depressive illness concept. But the DSM-4 and DSM-5 task forces have rejected his data and not included his recommendations. So here's the problem. The very same researcher and the very same data were acceptable for DSM-3 in 1980 and not acceptable for DSM-4 and DSM-5 20, 30 years later, even though there's even more data. And that's because DSM-3, 4, and 5 are conservative. They refuse to make changes based on science. Once something got in DSM-3 in 1980, it's very hard to change it after that, especially if it's any major change. Minor changes, they're okay with. Anything major, no. And this is why there's no increasing validity over time. So one example I gave you was the Jules Angst cohort study. The other is, another example straight from his cohort, is the duration of hypomania. So in DSM-4, they introduced 4 days for hypomania when they introduced the term type 2 bipolar, which was not in DSM-1. They had to have a cutoff for how long patients could have manic symptoms and call it hypomania as opposed to mania. Well, mania was a week long, so hypomania had to be less than a week. Should it be a day, 2 days, 3 days, 4 days, 5 days, 6 days? they picked 4 days because it seemed kind of in between 7 and 1. They had zero scientific evidence for picking 4 days in 1994. They still have zero scientific evidence that 4 days is a valid distinction between so-called type 2 and type 1 patients for bipolar illness, for the concept of hypomania. We've done 20 years of research. There's zero evidence that 4 days is a valid cutoff. There is evidence that 2 days is a valid cutoff. There's a number of good studies that 2 days is a valid cutoff, including studies, again, by Angst and others. But the DSM-5 task force, which was headed by Dr. Supis, who's going to be one of your speakers, refused to make this change. In fact, I talked with her about this, and I said, why aren't you guys making the change when the scientific evidence we have is that 2 days is a valid cutoff, not 4. So we have some evidence for 2 days and zero evidence for 4 days. She said, because we don't have enough scientific evidence to say that 2 days should be the cutoff. Well, that's an example of DSM conservatism. You make a decision in the past based on nothing, and then you refuse to change it because you say there's not enough research to change it, even though there's more than there was for what you chose earlier. These other examples here, we're not going to get into today, but let me just mention, I'm just going to throw this out to you and not provide the evidence for it. This is meant just to perhaps keep you up tonight and cause a little insomnia. Personality traits are very well established scientifically. Personality disorders are mostly disproven. DSM-5 task force in personality was going to drop the disorders and change the traits, but their decision was vetoed over the last few weeks and months by the APA leadership. And the term personality disorders was left unchanged in DSM-5 compared to DSM-4 20 years earlier, even though so many of those disorders are disproven as invalid. And the concept of personality traits, very well proven, is not in DSM. Prodromal schizophrenia has a decent amount of research to support the concept. It was not included in DSM-5 because there were many people opposed to the idea of possibly diagnosing younger children with schizophrenia and treating them with antipsychotics. Well, that may be a good pragmatic reason to be concerned, but it has nothing to do with science. The term dysphoric mood dysregulation disorder was included in DSM-5 based on very little scientific evidence to support it, all conducted by one group in the NIMH. And it was conducted by people who opposed the concept of childhood bipolar disorder and wanted to use this, another term, to encourage researchers and to encourage clinicians not to diagnose childhood bipolar illness. And that was admitted by the DSM-5 leadership, that the concept of DMDD was included to discourage researchers from diagnosing, clinicians from diagnosing childhood bipolar. Again, you may or may not agree that researchers should diagnose childhood bipolar less, but that's not a scientific decision, that's an opinion. That's your preference. That's the profession's preference, but that's not science. And so now we don't include diagnostic definitions like personality traits that are very well scientifically proven, and we do include diagnoses like DMDD that have very little scientific evidence because we just prefer it that way. So let me finish up on how this plays out in the case of mood illness. This picture shows you what I was describing earlier. Manic depressive illness before DSM-3 in 1980 was a very broad illness. It included patients who had depressive or manic episodes. It is not the same thing as bipolar disorder, which is depressive and manic episodes. Manic depressive illness meant either depressed or manic, not both. So what we call MDD, what used to be called unipolar depression in part, was called manic depressive illness. These are patients that had recurrent, severe mood episodes, either depressive or manic, often mixed. There were other patients who had other kinds of depressive states, melancholic depression that was chronic, not episodic, and neurotic depression, which was mild to moderate anxiety and depression. And these were not diagnosed as manic depressive. They did not have the same genetics. They did not have the same course. Neurotic depressed patients in particular did not seem to respond well to antidepressants, in contrast to the melancholic manic depressive patients who did. And the neurotic depressive patients often improve with psychotherapy more so. But the DSM-3 included all these depressive variants into the same bundle that they renamed major depressive disorder, as we mentioned earlier, combining these neurotic depressed patients with the recurrent unipolar patients that used to be called manic depressive. So DSM-3 created a very broad, heterogeneous MDD category, a very narrow bipolar category. As I said, there was a little scientific evidence to support this in the 70s, but that evidence has really declined over time. And as you can see, most of the genetic research now, these major genome-wide studies show that there's a major amount of overlap between bipolar illness and MDD. This genetic overlap argues that these are not different conditions, and it's supportive of the concept of manic depressive illness. Furthermore, the course of the illness for these conditions is not all that different. The claim was that bipolar illness had an earlier age of onset, and that the patients had episodes that were briefer. But unipolar depression was supposed to have a later age of onset in the 20s. But now many children are diagnosed with MDD who are 10, 12 years old. That's not different in age of onset than bipolar illness was. And we refuse to diagnose the bipolars at that age, which is kind of the reverse of the way it used to be. So both in terms of course of illness and in terms of genetics, the distinction between unipolar depression and bipolar illness has weakened over time. But DSM-4 and 5 refuses to make any change in this radical dichotomy of MD, manic depressive illness, into MDD and bipolar illness, as well as the addition of all these other types of depression, which, as Paul Voringer and I have described, really means that the MDD concept is a mix of various depressive states that are combined together. Just to point out, melancholic depression means very severe anhedonic psychomotor retarded depression. That's combined with mixed depression, which is depression with manic symptoms, or psychomotor agitated and very angry and labile. That's combined with other kinds like neurotic depression we mentioned, which is not even episodic at all, and it's very mild and anxious. And then there are other kinds that are starting to be recognized, such as vascular depression. Now, melancholic depression does not respond well to SRIs. It does respond to ECT and tricyclic antidepressants. Mixed depression does not respond well to antidepressants at all. It's more responsive to dopamine blocking antipsychotics. Neurotic depression does not respond well to antidepressants because it's mild, and the amount of benefit that's seen is similar to what you see with placebo. So they get better, but the difference with the drug compared to placebo is very small. So one of the things I think is happening with this problem of treating depression these days is that the MDD spectrum is so broad and heterogeneous and invalid as one concept for diagnosis, that drugs that are developed for depression may work for some of these subtypes, but don't work for other ones. And therefore, when you combine them all in the typical trial, you get a very small amount of benefit, which we see in various studies. I'm going to show you an example here. This is a classic meta-analysis about a decade ago, which showed that if you look at depression going from less severe on the left-hand side to more severe on the right-hand side, a basic major depressive episode, the benefit seen with antidepressants is in the red, with placebo, it's in the blue. The difference between antidepressant and placebo is small until you get to the more severe depressions. And the milder depressions, where the difference is very small, would comprise, I think, some of those patients that I'm calling neurotic depression, that we used to call neurotic depression, where they have just very mild symptoms. And so this is not to say that you don't get some benefit with the so-called antidepressants, but the benefit is higher in some patients, very little in others. And so overall, when you add all these numbers up, it averages out to a small amount. And you see this even in recent studies. So here's a meta-analysis that recently came out that claimed that antidepressants are effective. It got a lot of attention, published in The Lancet. First author says that this is the best available evidence for treatment. And when you look at it on the right-hand side, it does indeed look that the efficacy is quite good. But if you notice on the right-hand side, what you're seeing there are odds ratios. Odds ratios are relative risks, so how much better amount of improvement you see with a drug versus placebo if you divide it by the overall percentages. So for instance, if you had 30% of people with drug getting better and 15% with placebo, then that's 1.5, 50% improvement in the relative risk. Actually, no, it's 2.0, a doubling of improvement in the relative risk. You can notice that most of the relative risks are in the 1.5, 1.6 range. Let me go back one slide just to show you that here, the y-axis, I should point out, is Cohen's d effect size. And Cohen's d effect size is not the same thing as a relative risk. Cohen's d effect size is the actual overall improvement seen. And generally speaking, it's accepted that an overall improvement of 0.5 is moderate and above 0.5 is clinically meaningful. So a score of 1 and above would be quite high. So what you're seeing is benefit with both placebo and antidepressant that's clinically meaningful in these patients. The point is, though, the difference between the antidepressant and the placebo is small. And the difference, if you were to calculate how much that is, and you can probably see it visually, it's 0.1, 0.2, 0.3, the difference between the antidepressant and the placebo in many of these studies. And if you were to add it all up, it's about 0.3. So 0.3 is less than 0.5. So the difference between antidepressant and placebo is small. It's not clinically meaningful. Over the absolute effect is clinically meaningful, but the difference is not clinically meaningful. I hope you understand this so we can clarify this more in discussion if needed. But one thing that I would take away from this picture is that in clinical practice, if you give antidepressants, you'll see that patients get better. That's the red line. But what you don't see in clinical practice, because you're not giving placebo and you're not randomizing, is that that improvement would also happen with placebo. It would be clinically meaningful. It's above 0.5 in all these patients. And it's actually quite similar to what you would see with antidepressant for the majority of the patients. In other words, it's not the pharmacological mechanism of the so-called antidepressant that's making these patients better. It's giving them a pill, which might reflect psychological expectancy, but also reflects the natural history of the illness. You have someone with placebo patients is that when you have mild illness, like neurotic depression, the symptoms improve quickly. So back to this famous Lancet study, they're not showing you Cohen's d effect sizes, they're just showing you the relative risk. And the relative risk, it could be that 20% is better than 40% is better than 20, that's a relative risk of 2, that's fine. But it could be that 4% is better than 2%, that's still a relative risk of 2. But if only 4% of your patients are getting better instead of 40%, that's not many patients. So it's not really telling you how many patients get better. It's telling you how many get better than placebo. But to say that the drugs work, you have to show that the number of patients that get better is a clinically meaningful amount. In the case of this study, you have to go to the online appendix, which is 290 pages long. And if you go to page 150, you will find your Cohen's d effect sizes, which are here. And as you can see, most of the effect sizes are about 0.3, around 0.3, which is below 0.5, which is not a clinically meaningful difference than placebo. So this is the evidence that antidepressants are not very effective. They have mild symptomatic effects. Now, my point in saying all this, most people show you these data and they say, oh, the drugs just don't work well, or we have a lot of treatment-resistant depression, or we need better antidepressants and better mechanisms. These days, NMDA effects are everyone's favorite mechanism. My point is not that. I'm not saying the drugs don't work well. I think that a major reason why we get these kinds of results using the MDD definition is because the MDD definition doesn't work well. It's because the DSM concept does not work well. The DSM definition of MDD is not valid. And therefore, when you give drugs which increase serotonin reuptake blockade, you're not going to get a major benefit because you have lots of different kinds of depression mixed in the major depressive episode definition. Besides these pharmaceutical company meta-analyses that I've just shown you, the STAR-D study is another major study that gives us a little data on this. And this is an NIMH-sponsored study. And what I want to draw your attention to is the two bars, the green one and the yellow. I'll just mention the blue on the bottom is just tolerability. So you have some patients who do not tolerate the medications. But the green bar in the middle is the response rate when you take an antidepressant. First, in level 1, citalopram. Level 2, if you fail citalopram, something different. Level 3, if you fail those, something different. These are all randomized. And level 3 is tricyclics. Level 4 is MAOIs. The point I want to make is that at each level, when you fail an antidepressant, your response rate falls by almost 1/2. So that by the time you fail 3 or 4 antidepressants, even when you use our most effective drugs, which are tricyclic antidepressants and monoamine oxidase inhibitors, only about 15% of patients will get better. The other line I want to show you is the yellow line, which is in the group that gets better in the green line, what percentage stay well with up to a year of follow-up. So in level 1, which is citalopram, half the patients responded, but 40% relapsed despite staying on citalopram with up to a year of follow-up. And if you're lucky enough to respond at the 2nd, 3rd, and 4th levels to those drugs, and as you can see, it's only 15 or so percent of patients after a while, still 60 to 70% relapse within a year, despite staying on the same medication that made them better. So people often cite these numbers and they say 2/3 of patients will eventually respond to an antidepressant. And that's because they add up the green line. But they don't point out that the response rate goes way down after you've failed a few trials. And they also don't point out that of those 2/3, over a half do not stay well for even 6 to 12 months. So only about 1/3 get well and stay well for up to a year, which is obviously a small group. So the concept of treatment resistance to me is another mistaken concept, because it's not treatment resistance when the majority of patients with a diagnosis do not respond to the class of drugs for that diagnosis. When 2/3 don't respond in the long run, that's not treatment resistance. That's just an ineffective drug class. And then the last thing I want to show you with these depression studies is this meta-analysis of maintenance trials of standard antidepressants in so-called MDD, published by the Food and Drug Administration. And what you see here on this bar, on this chart, is the relapse rate benefit for antidepressant over placebo. And there is benefit up to 6 months, but after 6 months, it's basically at 0. Most of these studies actually are so-called enriched studies, randomized discontinuation trials, where patients are pre-selected to be effective, to have efficacy with the antidepressant being studied. In my view, those are invalid trials. They are almost always positive. The FDA accepts them for indications. So in these 15 studies or so, most of the drugs are indicated. They have FDA approval for long-term treatment. But as you can see, the difference between drug and placebo is almost always in the first 3 to 6 months. These studies are not showing efficacy for long-term treatment. They are not showing that the drugs are effective a year later, 2 years later, 5 years later. They don't even show efficacy 6 months later, which is consistent with the STAR-D study, where when you follow people up for a year, the majority relapse. And this gets to my point that antidepressants, so-called antidepressants, are not disease-modifying drugs. They may improve depression symptoms mildly, as we've seen, modestly, immediately. But those effects only last a few weeks to a few months, and long-term, they don't have any benefit in preventing depressive episodes. In contrast to the common practice of using these drugs for years and years and years, I think this research suggests that we are practicing without any scientific basis for long-term efficacy. So what should we do? Well, I think that what we need is a new research diagnostic criteria. We need to go back to the 1970s, but not in the same way. The one thing DSM did give us was reliability, as I mentioned. We use the same terms. But unfortunately, the dictionary became a Bible. It needs to become a dictionary again. It needs to change. We can't worship it. And we need to use diagnostic criteria based on clinical research only, not any other pragmatic or professional considerations. In other words, we have to be honest. I do not accept and I do reject the NIMH's solution, the research domain criteria. They pretend that that's a better approach, but that's just made up by a different group of leaders. In this case, they are researchers in NIMH, but their focus is on brain research. They think that DSM failed because it was clinical research. So they think the solution is non-clinical research, brain-based research, genetic studies, and neuroimaging studies. Well, That's not proven. My hunch is that it will fail, but certainly to claim that that's the only approach we should take is not scientifically legitimate, because in science, we shouldn't enforce one way of thinking. We should allow researchers to use many different hypotheses. I think the problem is that DSM failed because it did not use clinical research. That was not its primary criteria. Like I said, its primary criteria were non-research, postmodernist, pragmatic, professional considerations. Clinical research hasn't even been tried as a basis for psychiatric diagnosis. It was in the research diagnostic criteria in the early 1970s, but then it was dropped with DSM-3. Most of the people involved in the original RDC left the DSM-3 task force because they were disgusted by the non-scientific attitudes taken. I think we need to return to a purely scientific approach to research diagnostic criteria. By the way, this is what every other profession in medicine does. You know, there are diagnostic criteria for epilepsy and for migraine in neurology. The groups, the committees for those criteria are only researchers. They are not non-researchers who just have an opinion that they prefer. And it's not run by the American Academy of Neurology. It's not based on a professional organization. It's only based by research organizations. That's the way we should do it. That's the approach we should take. And if we do that, we'll have a scientific diagnostic system that actually will improve scientific research. And also, you know, when we don't know, when we don't have the data based on scientific research, I think clinical judgment of experienced clinicians should be legitimate. And we shouldn't be enforcing everybody to think exactly the same way as the DSM system does. Science is not authoritarian. It has to be democratic, which means that people should be free to have different opinions. So the final themes of putting it together for you is the DSM is a social construction. That's a good phrase to emphasize, as the postmodernists like to say. It's something created by society. It is not scientific reality, and it does not use scientific concepts as its primary criteria. Reliability was obtained, but validity was not. Pragmatism became the primary way of thinking with DSM, which made it more conservative over time, which made it more difficult to actually improve it and make it more valid scientifically. And this doomed psychiatric research, and will do so if the criteria are still used in the future. And it also, I should add, impairs psychiatric practice. And it makes us practice in a way that is very limited in its clinical benefits for patients. And I think patients deserve better. And we as clinicians also deserve better. I think we should stop ceding diagnostic concepts to organizations that tell us what to do. Rather, we should have the research tell us what to do, and then we should exercise our clinical judgment. Thank you for your attention.
Muchas gracias, Nassir. Me parece que es una tremenda presentación. Creo que la forma en que has presentado, en particular, los trastornos del ánimo, bueno, se acerca mucho a lo que es la tradición de la psiquiatría chilena, donde nosotros hemos tenido la influencia de la fenomenología de la psiquiatría alemana desde siempre, y el concepto que nosotros tratamos de enseñar a los estudiantes de posgrado es que esta forma de verlo, yendo al ejemplo de los trastornos del ánimo, es una visión que es una visión muy krepeliniana, que es lo que finalmente Jules Sanz ha demostrado. En realidad es la misma enfermedad, el trastorno bipolar y el trastorno unipolar, solamente que varían algunos genes, es un cuadro poligénico, pero que es la misma enfermedad. Y una de las razones por las cuales nuestra sociedad, la Sociedad Chilena de Trastornos Bipolares, en realidad va a cambiar su nombre y va a dejar caer la B larga para pasar a llamarse Sociedad Chilena de Trastornos del Ánimo, es porque esa es nuestra impresión clínica, y es lo que nosotros vemos con nuestros pacientes. De tal manera que agradecemos esta presentación, Nassir, de verdad muy importante. Hay varias preguntas que han planteado los asistentes a esta presentación que la va a hacer el doctor Feringer. Queremos decirle que 403 personas ingresaron a la reunión, lo cual es un número realmente muy importante y que da cuenta del interés que despertó tu presentación, Nassir. Paul.
Gracias, Jorge. Para tener una fluidez mayor con Nassir, las voy a hacer en inglés para que sean traducidas. ¿Ok? Are you okay with that, Nassir?
That's fine, Paul. You could also, it's however you like, either way.
Yeah. First of all, I just want to thank you about, putting Europharma as a support industry for our lithium trial. I think that's a very, very important trial, Jorge, as well as with us doing this trial. And I want another word of you in this concept, which I think is truly important, the disease modifier agent. And if you want to go a little bit further about lithium and disease modifier regarding, especially maybe dementia, you have just little words about, I think it's a little bit out of the scope, but a few words about dementia and lithium.
Sure. Yeah, so lithium has been shown to be neuroprotective in animal studies, in cell studies, and in humans. By that, we mean that when you give lithium and look at neurons, the neurons live longer, they survive longer, and they also grow. They have attachments, axonal growth that happens. This is unique because there are some other drugs classes that can show some neuroprotective effects, such as the serotonin reuptake inhibitors, the dopamine blockers. They do show some neuroprotective effects in some studies in animals, some animal studies, but then they don't show it in other studies, and they don't show it in humans, not consistently at least. Whereas lithium shows it across the board. It's the only medication consistently shown protective across. Or in human studies, we have a lot of data now with lithium, and observational data like Ank's Zurich cohort study, which was very useful because he studied people from age 20 until their 70s and 80s, until their deaths. So he really had prospective data on occurrence of dementia in these patients. And what he found was that lithium was the only drug associated with lower dementia rates. All the other drugs, the antidepressants and antipsychotics, were associated with higher dementia rates. The risk of his dementia was 4-fold higher in the mood disorder patients in Zurich cohort compared to the general population normal comparator group that he also followed prospectively for the 20 years. So by the late 60s, close to age 70, about 20% of the patients in the Zurich cohort with unipolar depression or bipolar illness had dementia, 20%, compared to 4 to 5% in the population control group. Lithium reduced the rate to 4 to 5%. The lithium rate was the same as the population norm, and it was much lower than the other mood disorder patients. Now, there have been a few other studies that have looked at it. There have been studies of lithium in the drinking water in Scandinavia that show lower dementia rates with higher amounts of lithium in the water compared to lower. There have been a couple randomized trials now, including one in Brazil, done with very low dose lithium, trace dose lithium, which is similar to the very low doses in the water, which found reduction in progression of early Alzheimer's disease compared to placebo. There have been 4 or 5 studies. We did a systematic review of this a few years ago, and the majority of those studies find some benefit. However, the studies are not large enough, they're not long enough to be definitive, and there have been no studies that are randomized of patients with mood illnesses. The Zurich cohort was an observational study. So what you want to do is to take those data that Ank's presented in Europe and do a randomized trial to really prove the benefits due to the lithium as opposed to other possible reasons. And if you can do that, it would add to the rest of the literature supporting the concept of benefit in dementia. And the other thing to point out is that patients with mood illnesses are a high-risk group for dementia. So they're the perfect patients for this kind of study. Most of these studies are done in general population. Sometimes they'll try to pre-select ApoE4 gene heterozygous people, but it's very hard to actually recruit those patients. But mood disorder patients, we have a lot of them. And if you capture them in middle age, 50s and 60s, and follow them, you should be able to show progression into dementia because the baseline rate was 20% by late 60s. And that's the idea behind this kind of research. And the other thing to point out is the amount of lithium in the drinking water that's considered high is equivalent to about 25 milligrams of lithium carbonate. 25 milligrams. As you know, the smallest pill size is 300 milligrams, and we normally diagnose around 900. So the amount that we need to give older people to prevent dementia is very small. It's probably 1/30th the dose we use in bipolar illness. So a lot of times the main concern people have about lithium is, oh, it has so many side effects, so many risks, it can make you toxic, especially older people. But these doses are so small, there's no way people would get toxic with it. It would be undetectable in the blood, but it could have major benefits. So these are some of the reasons why doing this kind of research is really so important, would really be a breakthrough if it was conducted and showed benefit.
Thank you, Nassir. A couple of questions. For example, sorry. Jorge?
Could you comment a little bit on the augmenter effect of lithium? You know, but because what we usually see is the use of many other augmenters from the so-called antidepressants, and they don't indicate, they don't prescribe lithium, that it's known to be the best augmenter from the so-called antidepressant. Could you comment a little bit on it?
Sure. So the amount of benefit you see with a standard antidepressant in these placebo-controlled studies, as we said, is small. I described it in terms of Cohen's D, but maybe a better way of describing it is the change in the depression rating scale score. So for instance, if you have a Hamilton depression scale, usually people have scores around, say, 30, and if they have an improvement, they go to 15. That's a 50% improvement. Now, with the drug, say they go to 15, and with placebo, say they go to 17 or 18. So they're improving with placebo too. And the difference between the drug and placebo is about a 2 or 3 point improvement, 15 versus 17 or 18. Mm-hmm. So it's a 2 or 3 point difference between drug and placebo. That's the amount of benefit you get with standard serotonin reuptake inhibitors. And 3 points is considered the borderline of a clinically meaningful effect. So the FDA will give a company approval for a drug for the market if it can show a 3 point difference between placebo and the drug. But 3 points means, you know, if you have a score of 30, and you go to 15 as opposed to 17 or 18, the difference may just be that you sleep a little better, or you eat a little more, or you're a little more active. It's not a huge difference. It's the minimal clinically meaningful effect, they say. Now, in the case of esketamine, for instance, which is recently out, the difference was 4 points. So we're still looking at relatively small differences. So when you say augmentation, if you start with a 2 or 3 point difference and you give something else to get another 2 or 3 point difference, that's kind of the idea with augmentation. But I think the problem is a bigger one. I don't think that lithium is useful to augment antidepressants, because I think antidepressants are so weak in their benefit that 2 or 3 point difference is nothing practically. And so it really isn't a problem of augmentation, it's a problem of inefficacy. And if you give lithium, you might get a 4 or 5 point difference instead of a 2 or 3 point difference. You don't need to augment, you just need to give the lithium. In fact, there are meta-analyses from the 1970s where there were studies directly comparing lithium and tricyclics. And the antidepressant efficacy of lithium was equal to or better than tricyclic antidepressants by itself. Yeah. And we already know the tricyclics are more effective than the serotonin reuptake inhibitors. So I don't think it's a problem of augmentation. I think people need to stop using serotonin reuptake inhibitors so much and just start giving other drugs like lithium and maybe some of the dopamine blockers if they have mixed depression. For me, what's more important is identifying the phenomenology of the depression to know what to give. And the biggest problem is that the DSM definition of MDD is a failure and does not help us in making treatment decisions.
Absolutely. So a couple of questions here. For example, what do you think about treating in a long term with antidepressants, or for example, for the so-called mood instability in personality disorders? These are questions from the audience.
Well, so as I said, most of the personality disorders, in my view, are invalid scientifically, and they aren't diagnoses we should use either. And in fact, it's very clear with DSM-5 that was the one place where the DSM leaders got close to making a scientifically legitimate decision, but then they backed off at the last second. So if we're talking about, narcissistic, etc., I think it's not useful. But if they mean borderline personality, where people often refer to mood instability, again, you're engaging in symptomatic treatment. I think that's the key issue. You're not treating an underlying disease. You're not curing the borderline personality with an SRI. You're trying to reduce the amount of anxiety the patient has, maybe or some sadness, mood symptoms with the SRI. You'll get a mild benefit with that, just like if you gave Tylenol to somebody who has pneumonia, but you don't treat the pneumonia, you'll get a mild benefit for the fever. But that's not a long-term solution to anything. And again, the Hippocratic approach is if you treat patients with symptoms, just for their symptoms, in the long run, you cause more harm than good. That's been the history of medicine, and it's going to be the same with the SRIs. So I would be opposed to such long-term treatment in personalities.
Okay. So, Dr. Barole, you know him?
Yes.
Asked about the ICD-11, if this kind of classification is following the same path as DSM-5.
Yeah, unfortunately.
Do you have any clues about that?
Yeah, the ICD system is based on a European organization. And it's not the American Psychiatric Association, but unfortunately, ever since DSM-3, the ICD system organizers have coordinated their criteria with the DSM system. So they basically follow what the DSM system says in almost all issues. And therefore, it's not really a difference, and it's not an alternative.
Right. I know it's not your arena, but any words about this heterogeneity in the mood disorders classification in children? Any thoughts about that? Somebody else?
No, unfortunately, I think the DSM-5 was successful in introducing the DMDD concept so that they could confuse clinicians and researchers for the next 10 to 20 years. Instead of having them do good research in children, they'll do fake research with an invalid concept, DMDD. And I think that's really distracting people from doing more valid research. From what I can see, there's some interesting work that some people have done with bipolar illness in children and trying to get at the phenomenology of it. But I don't see any work really being done carefully on depressive subtypes.
All right. Here are asking about the subtype mixed depression of DSM-5. What do you think about this?
So that deserves a lecture on its own. As you know, the concept of mixed depression is very important in my view, as are the concept of affective temperaments, which we haven't mentioned, which I think are actually more important. Mood temperaments like dysthymia, hyperthymia, cyclothymia. DSM does not have hyperthymia in it at all. And cyclothymia is not defined as a temperament. It's defined as, it's actually unclear what DSM means by it. Mixed depression, or so-called MDD with mixed features, as the DSM-5 has set it up, could have been some progress in terms of depressive subtyping. I mean, it's interesting. If you look at DSM, it does have the melancholic feature subtyping. It now has mixed feature subtyping. It has anxious feature subtyping. But they won't come out and say that MDD with anxious features, they won't describe it as something different, like neurotic depression. Or MDD with melancholic features, they won't describe it as a different kind of depression, like melancholic depression. And MDD with mixed features is a different kind of depression. It's mixed depression. And the view that Koukopoulos, who was my mentor on this, and yours as well, had about this was that mixed depression, as I described it, is an agitated, angry, labile depression. Mm-hmm. But the way the DSM-5 system set it up, they wanted to, they were afraid to use that diagnosis because they were afraid that too many people would be diagnosed with mixed depression. So they introduced the concept, but they decided to make it narrow leaving out irritability and anger and lability as part of the diagnosis, and requiring that people have non-overlapping, quote unquote, non-overlapping symptoms, which essentially means having euphoric type symptoms. Well, patients who are mixed aren't euphoric, the majority of them. And so that really is a very small group. It's a classic example of the DSM system using concepts that are non-scientific. The reason they left out the anger and the rage is because they thought it would diagnose too many people, and they didn't want to do that. But my problem with that is, why is it up to them to diagnose, to decide how many people get diagnosed? Again, Dr. Suppies was the leader of that group, and she's been very clear. They thought it would diagnose too many people. But that's a classic pragmatic, professional, non-scientific judgment. And so unfortunately, MDD with mixed features and DSM is kind of a narrow group that isn't really reflecting the majority of the truly mixed depression patients. I should say, I'd add to you that since I've had some experience now with drug development research in the last few years, what I've learned is that the FDA requires the MDD definition for new drugs. And the FDA is opposed to subgrouping it. So there's never been a drug that's been developed for MDD with melancholic features. And the reason is the FDA won't accept that. It only wants an MDD general definition. So even if you wanted to develop a drug for MDD with melancholic features, you would have to show that it also worked in MDD with non-melancholic features, which is, it doesn't make clinical sense, but that's the perspective they have. A few years ago, Synovion developed this drug, lorazepam, as you know, Latuda, for it's out in the market for bipolar depression, but they showed that it was effective in MDD with mixed features, this very definition. They showed efficacy. The drug was effective, better than placebo. They took it to the FDA, and the FDA refuse to give them an indication for it because they don't want to indicate subtypes of MDD. And it's not just the FDA's issue, because what the FDA does is it consults with academic experts. And because experts are DSM biology, they don't want to subtype it either for new drugs. They want to keep the MDD concept as a whole. So unfortunately, the whole profession and the whole drug development system is working against anything that's a treatment for subtypes of depression.
I think maybe the last, not least, maybe a few words further going into the research domain criteria or research-based criteria you just mentioned as a possible solution to going around the actual classification.
Yeah, I think the research
closing remarks.
Yeah, well, the research domain criteria were developed by NIMH leaders who were animal researchers and genetic researchers. They were not clinical researchers. And there's always been a bias in the NIMH against clinical research. If you look at the studies that get funded by the NIMH, 80 to 90% of them are non-clinical research studies. They're mostly biology studies, genetic studies, neuroimaging studies. So the leadership of the NIMH always was opposed to clinical research, or didn't view it as being very important. That's part of it. And then the other thing that's relevant here is, if you think back to 100 years ago, there were two major approaches to diagnosis in psychiatry. One was Kreplin's, which was clinical research, and the other was Wernicke's, which was brain-based research. As we know, Wernicke is famous now for Wernicke's area of the brain, but he was a chairman of psychiatry, and he wrote a textbook of diagnoses based on brain anatomy. Now, even though he was the expert, greatest brain anatomist of his time in 1908, or around then, the neuroanatomy of that time is definitely not useful for psychiatric diagnosis in 2020. But Kreplin's clinical research has proven useful and actually may be more valid than a lot of the clinical research that people have proposed after him. In other words, one of the problems with taking a brain-based approach to diagnosis is you're very limited by the technology and neurological knowledge that you have at the time. And so even the best knowledge we have in 2020 is not going to help us in 2025 or 2030. Another aspect of that too is the assumption with the NIMH brain-based domain criteria is that if you work from the brain out, that the brain, changes in the brain will correlate with diagnoses in the real world. But as you know, multiple diagnoses in the real world can cause the same change in the brain. Multiple diseases can cause the same change in the body. Just give you an example. If you have pneumonia from streptococcus, or you have pneumonia from staphylococcus, from tuberculosis, let's say, you're still going to have inflammation of the lungs, both ways. Inflammation of the lungs is not diagnostically specific. It can be caused by multiple diseases. And the NIMH research domain criteria assume that a change in the brain is diagnostically specific, going to be diagnostically specific. And you can't assume that. Sometimes it is, but frequently it's not. So I'm not opposed to doing the brain-based research and genetic research, but I don't think it's going to give us diagnoses. I think it'll be out of date, like Wernicke was. And I think its assumption, it's missing the fact that it's assuming that multiple diseases can't cause the same change in the brain, which they do. So I think it's not going to be a success, and I don't think it's a solution.
Thank you very much, Nassir. Jorge.
Ok, muchas gracias, Nassir, por tu presentación. Te agradecemos de nuevo y esperamos vernos pronto en Chile, pues que venga para hacer una evaluación del proyecto del uso de litio en dosis pequeñas, 25 miligramos para prevención de Alzheimer. Así es que te agradecemos nuevamente y damos por terminado esta sesión del ciclo de educación continua de Subtype. Muchas gracias.
Gracias, Nassir. Así que vendrás acá a ayudarnos con el estudio.
Sí, gracias. Gracias a ustedes y gracias a toda la gente que han estado con nosotros esta noche.
Okay.
Cuídate mucho.
Adiós.
Adiós.
Chao.